All right, so I'm recording on my end, so you won't get the notification there, but I'll post this up afterwards just so you guys can have access to that. And of course, if you have questions, either pop them in the chat. Feel free to interrupt me if you want. Put them on the sticky board. Any of the above is totally fine. I will not take offense if you interrupt me in the middle of lecture. Okay, so we were covering the kind of tail end of the oncology section here. Went over most of the kind of common run-of-the-mill older set of cancer drugs that are generally pretty non-specific, right? So we mentioned how they kind of attack both cancerous cells but also healthy cells. And so really the challenge there being is that you're causing a lot of collateral damage, you're hurting these healthy cells, and that's what leads to a lot of this issues in terms of immunodeficiency, and you end up seeing like the stomatitis, so like nutrition's a problem, and like fluid intake, alopecia, all that bad stuff. So now switching gears a little bit, we're talking about sort of newer sets of drugs that are designed to sort of be more specific for these cancerous cells. So the idea would be if you can target cancer cells specifically and avoid all that extra collateral damage, then overall the side effect profile should look a lot better. And I think you'll see some examples of that coming up here. Now, a lot of these tend to focus on, and we call these biological response modifiers. And so you'll see kind of what I mean by that here in just a moment. One of the ways we can do that is actually by targeting something called protein kinase receptors. And so we've talked about these previously back in pharmacodynamics for a short period there, but they're a really important set of receptors that are responsible for causing a lot of like cell growth and cell differentiation. And so you'll find a lot of examples of those, for instance, like insulin receptors. So by binding insulin receptors with insulin, that causes glucose transporters to be placed on the cell surface. So you suck out glucose out of the blood, and then your cells now have energy, right? Or they can produce energy. But more importantly, for cancer purposes, we see this happens a lot with different things like epidermal growth factor, right? Or things like vascular endothelial growth factor, things that may influence the growth of these cancerous cells by providing extra blood supply or things like that, right? And so we have a lot of different varieties that are out there. I'll just cover a few here and some of the medications that may interact with them. And again, here you can see how these receptors work, where basically you'll have a signal molecule, you'll have to have two of them that will come in, they'll bind to these, they'll dimerize, they get phosphorylated, and then you see whatever cellular response happens downstream. And it seems like it's pretty straightforward, but for instance here, you can see an example of an epidermal growth factor receptor, right? So it gets bound to by the ligand, it then gets phosphorylated, and you can see all the different pathways that get activated that lead to cell survival, that lead to proliferation, that lead to all these different things that allow for, if this is a cancerous cell, to continue to grow and replicate and potentially harm your patient, right? And so the goal here is if we could target these specific receptors, especially ones that are only present on cancerous cells, then you're going to be more specific and you're not going to hurt a bunch of healthy cells. So here are some examples. We have two here, imatinib and then gefitinib. Typically, if it ends with a nib on the end, it's probably going to be a tyrosine kinase receptor antagonist. And so you can see that these are very specific though, right? So they're very specific for certain types of cancer. So in the instance here of imatinib or Gleevec, this is specific for CML cancers or CMML that have these specific mutations. So if you have this BCR-ABL mutation, then this drug would work for you. If you didn't have that mutation, then the drug's not going to work because you don't express those receptors that would be would interact with the drug itself, right? So again, the problem with these are though is that because they tend to be more narrowly specific, not every patient can benefit from them, right? If I have a patient with CML and I give them cyclophosphamide, it's going to kill off a lot of cancerous cells. But if they don't have this mutation, then imatinib is not going to be great. Okay, so there are a bit of a downside from that standpoint. You do have to do flow cytometry to figure out what kind of cells they have, what kind of receptors they're expressing, and all of that. But you can see here, they decrease the myeloid TK responsible for cell proliferation. So the tyrosine kinases here. So that way they have less incentive to grow because they're just not getting that signal, right? And look at the side effect profile. Some nausea, vomiting, maybe some edema. Sounds a lot better than like excessive immunosuppression, alopecia, stomatitis, all that other bad stuff you would see. It's also not likely to be carcinogenic or mutagenic like you would see with a lot of like the alkylating agents. So again, you get a lot less side effects, but it's also a much more narrow patient population you may be able to treat there, right? Depending on how common those mutations are. Gefitinib, kind of the same thing. You could use it for something like non-small cell lung cancer. And again, side effect profiles which seem pretty mild as compared to kind of what we were seeing previously. Here's one called erlotinib, which is actually going to be used for different types of cancers like, small cell lung cancer, pancreatic cancer, and this just targets an epidermal growth factor receptor, right? So this is actually responsible for causing some of the growth of these tissues here. You block that, you prevent the cancer cells from replicating. Now, again, indications I'm not going to ask you specifically on, but the concepts here is what I'm trying to get at, is that these, again, are more targeted. They're going to be less side effect prone, but also useful for fewer patients overall. Just another example here. Here's lapatinib. This one's going to be used for breast cancer as an example. And you'll see some of these drugs are going to be beneficial if patients become resistant, say, to other treatment. So if they continue to have progression of breast cancer despite being on another drug we'll talk about in a minute here called Trastuzumab, then you can end up developing a resistance, and you can use this drug as an alternative there. Marley's asking, is it important for us to know exactly which TK they inhibit? I'm not going to get that specific. I'll tell you right now. In terms of mechanism, if you know that these, and you can identify them as tyrosine kinase receptor antagonists, I'm okay with that. I'm not going to get super granular because there's a lot of mechanisms we've talked about in this section here, and I want you to be able to kind of get the more coarse sort of definitions there, right? Be able to recognize an alkylating agent versus antimetabolite versus a topoisomerase inhibitor, etc., right? If that makes sense. So that's kind of more so what I'm going to be going for there. And again, you can see, just as an example, if you combine capecitabine, which is a drug we talked about previously, along with something like this, you can see that the tumor growth time, the doubling time, goes from 4.4 months to 8 months, right? So basically kind of decreasing by 50% there. So it takes that much longer for it to grow. So really important for cell proliferation and growth are these tyrosine kinase receptors. Again, very mild in terms of side effects as compared to a lot of other things that we have seen so far. So next up, I want to talk about antibodies, and actually this is another really important thing. Actually, there's a video I might send you a link to. There's a YouTube channel for JAMA, which is the Journal of American Medical Association. They just had a video that I saw in my feed about monoclonal antibodies that they're developing potentially for treatment of COVID. But we've been using these for years now. And so basically, as you know, anything that ends with a MAB is a monoclonal antibody. It's an engineered antibody that we have that we can administer to patients to neutralize a specific target. Those antibodies will bind to it, neutralize it, and then our immune cells can come in and kind of wipe up the rest of it, right? So things like Rituximab, Alemtuzumab, Trastuzumab, Rituximab, and then Bevacizumab. Again, a lot of these are typically hard to say, and I spelled that one wrong. So Alemtuzumab. So just know if you see MAB on the end of the name, it's going to be a monoclonal antibody. And actually, frequently, what's kind of neat is you can look at this portion of the name here. So this will actually tell you whether or not it's more of a chimeric protein, whether it's a humanized protein, or frequently if it's a more of a murine protein. So murine being mouse versus humanized. That does have some implications in terms of some of the side effects we're going to see. And I probably mentioned this before, but for instance, things like allergic reactions and anaphylaxis, you're less likely to see this with natural-looking proteins like human proteins than you would if you were to inject murine proteins, right? Because you are likely not a mouse. I think that's one of the prereqs to get into PA school is you have to be a human being. But once you made it in, if I were to give you mouse proteins, you're more likely to have a reaction to that than you would be if you were to inject with human proteins. I can tell you, even certain animals, between animals, you can see differences in anaphylaxis. So just to get slightly off topic here, when you're looking at snake antivenom, you can actually see that if you have antibodies that were, if you immunize horses against certain snake venoms versus sheep, people have a lot higher cross-reactivity with horses and much more likely to see anaphylaxis than we do with sheep. Why that is, I have no idea, right? But it's kind of interesting to see that there. A lizard person. Well, there actually is a drug that comes from the Gila monster. So quite a little bit off topic there with the lizards, but actually certain drugs we use for diabetes and some degree of weight loss, you can actually come from the Gila monster. So it's kind of interesting there. Actually, yeah, it's very true. Their science is way ahead of ours. So anyway, so again, usually the names are difficult to say, so that's why I try to pronounce them there for you. And you'll see these are used for different indications too, outside of cancer. You may see these being used for a lot of like rheumatologic conditions, as well as we're going to see here in just a moment. So Rituximab, this is a common one. I almost use this every single day that I'm at Nemours for patients coming into our infusion center. It's very commonly used for a lot of like rheumatologic conditions. We may use this for certain autoimmune kidney disease and things like that. And again, you can see the X here, so kind of like a cross between two different types of proteins. This is a human murine antibody. Do I care that you can identify if it's human or not? No, of course I don't care if you know that. I'm just kind of talking about it because I think it's interesting. But this is a specific antibody to the CD20 antigen on B lymphocytes. So as you might imagine, you can see here that would be useful for something like a lymphoma where they're expressing a lot of these B lymphocytes. And so you can see here that 90% of non-Hodgkin's lymphoma actually expresses CD20 antigen. So this gets very specific for that particular type of cancer, whereas it may not be effective for a lot of other types there, for like other types of leukemia, for instance. And so by binding that up, by binding the CD20 receptor that normally helps with cell cycle activation, you kind of prevent those cells from going into mitosis unless they cannot replicate as quickly there. And once it's bound up, then you have that complement mediated lysis that comes along. Remember, your complement system will come in and then help to get rid of those cells there. So you're helping your own immune system identify the cancer cells to take them out, essentially, which is kind of neat. So things with the monoclonal antibodies you're typically going to see is that frequently there are a few that you can give like a self-injections that patients can give at home. So I'll give you a few examples of those later probably. But a lot of times they're weekly infusions, or they may be like every few weeks or so they have to come in. So that can be a challenge for patients, especially if they work or if they're parents of children that have to come in and get these infusions done, as it does take some chunk out of your day for sure. But just as an example, they'll come in for 4 weekly infusions once a week. The half-lives of these drugs are pretty long, given the fact that there are these proteins that stick around for a while. But the side effects here are what I really wanted to focus on. So these infusion-related flu-like syndromes. So a lot of patients will get this, and so it's important to consider what are the adjuvant medications you're going to use to prevent that from occurring. So for instance, if you know they're going to get chills and fever, then something like acetaminophen might be a really good drug to pre-medicate them with to prevent that from happening. If you know they're going to get rash and itching, pre-medicate them with something like some diphenhydramine. A lot of patients have significant enough reactions. We will actually pre-medicate with something like a corticosteroids. We may give them methylprednisolone, dexamethasone, something like that, in order to prevent those reactions. So you can give that as pre-treatment, and then you want to consider too, what if they have an anaphylactic reaction after, or once they're getting the drug itself? And then you always have to make sure you're ordering for that as well. So a lot of times, if you guys are familiar with order sets, these are things that we pull up when we're ordering medications for patients. So you could type in Rituximab for cancer or whatever, and it would pull up all the medications you'd use there, including this drug, a lot of nursing orders and stuff like that. But there's always going to be a section there for anaphylaxis, just in case the patient does have an issue that pops up. The nurses are able to react to that. They can pull out the epi, they can give the steroids, X, Y, and Z. So again, pre-medication is very important there. Also consider the risk for anaphylaxis afterwards, okay? And you can see here that bronchospasm, nausea, vomiting, that all makes sense related back to the immune reaction you can see there. It should be already, I don't know why I have so many typos in here. It's kind of embarrassing. And of course, you can see some mild myelosuppression as well, which makes sense because you're inhibiting a lot of those B lymphocytes there, right? Alemtuzumab is again shooting for a different target. So this one's engineered to go against the CD52 antigen found on T and B lymphocytes, and so it's useful for those lymphomas as well, for certain types of CLL, etc. Notice the reactions here are going to be pretty similar, infusion-related reactions. Those are exactly what I was talking about last slide, about the flu-like syndromes you can kind of get along with these infusions here. But remember, the more widespread its activity is, so again, here it's affecting both T and B lymphocytes. You can see here that risk for opportunistic infection may go up, right? Because you're suppressing that immune system to a degree, so they may be at risk. So again, just because, we typically think about cancer patients receiving chemotherapy, but if you have someone who's taking this drug, for instance, for something like, it probably wouldn't be like rheumatoid arthritis, but for another condition, you have to think about them as being at risk as well. So if you're trying to warn them, hey, make sure you're wearing a mask out there, it's even more important because you are an at-risk population for getting infection, flu, COVID, and all that good stuff. Trastuzumab is going to be another one. This is actually going against the epidermal growth factor 2, or the HER2 in the receptor here. And so this is actually kind of similar in terms of the tyrosine kinase receptors, but it's actually an antibody that's binding to it to neutralize it. And so it's able to downregulate that growth factor receptor. It's able to prevent binding of the normal growth factor. So again, you're inhibiting the cells from replicating here. And again, here's an example of another targeted one where this is better for breast tumors that expresses HER2 oncogene. Basically a way to say that, it's expressing a cancerous mutation, essentially. Allison was saying she shadowed in an infusion center and saw a patient who reacted to his infusion. He was shaking like crazy and got really cold. It was scary to see. That's exactly what it is, right? So you can see that. You'll see itching, rash, just depending on what sort of flavor of reaction they're having to it. That's why pre-medication is super, super important. I have some patients who get really bad GI upset with these because of the histamine they're releasing affecting H2 receptors in the GI tract. So oftentimes we may have to give them things like, famotidine and omeprazole or something like that to prevent reflux and vomiting associated with that. So it really just depends on the patient, how they react. Nice thing too, these patients are coming back over and over again. So you kind of know what kind of reactions they're going to have. So you kind of know, okay, this particular patient, they're going to need this type of cocktail of medications as pre-treatment versus someone else who may not require as much. So, and you can use these drugs in addition and in conjunction with some of the older school drugs we were talking about. So here's an example of using it with doxorubicin plus Taxol. By using these together, again, you get better synergy and can overcome some resistance here. Again, toxicity, very similar with all of these as we mentioned. Now, there's a drug here I mentioned called meperidine. Meperidine is actually an opioid analgesic, but if anyone's ever heard of the drug Demerol before, Demerol, I had a pain management pharmacist that I knew who called it Demonol. She hated this stuff because it was really bad to use for pain management for elderly patients because they tended to accumulate some of the active metabolite and you saw seizures associated with it. However, meperidine has a very specific case, and Allison, I thank you for bringing up your example there, because this might have been a case that would have been useful from meperidine, because they call that rigors when they're shaking like that, and so you can actually use meperidine to treat those rigors in order to help inhibit that. So sometimes you'll see that in surgery. So we will sometimes use this in other cases, for instance, like therapeutic hypothermia. So if someone has like a witness cardiac arrest and we're trying to cool them down, they oftentimes will shiver because their body's trying to heat themselves back up and they don't want that. So they'll actually give them a meperidine to inhibit that. So again, depending on how the patient's going to react will dictate what medication you're going to be using there, right? This one's kind of interesting though, because you do get a unique side effect of this cardiomyopathy. So again, doesn't seem sensical based on the mechanism, but again, something they've noticed at least in the trials and post-marketing surveillance. Rituximab is another one here that works on the HER1 epidermal growth factor. Again, different types of cancers you're going to be using it for. Again, don't worry about the actual indications. I'm not going to ask that on the test. But a wide variety of different types of cancers can be expressing this HER1 receptor, so it allows the drug to be effective there. Okay. And then Bevacizumab is another one for vascular endothelial growth factor, VEGF. This one actually affects angiogenesis. So this is kind of a neat one because if you can strip the tumor of a blood supply, if it can't get oxygen and nutrients to it, then it cannot replicate any further. And so this is basically cutting off the supply line, so to speak. And so that can be useful for, again, a variety of different types of cancers here. This one's really interesting because its effects on angiogenesis can actually affect your blood pressure, right? So maybe by affecting growth of new capillaries or something like that, it can cause severe hypertension, CHF, and proteinuria. So kind of an interesting set of side effects based on how it's actually working there. So here's a novel mechanism. This isn't really going. This is another protein-based one because you can tell it's a enzyme because ASE on the end there, so you know it's an enzyme. But this one's kind of interesting. It's called asparaginase, and sometimes you'll see it called like PEG asparaginase. It's kind of a different flavor of the drug, so to speak. But this one's actually where it's affecting the amino acids that are required by some of these cells here. And so this is kind of a novel mechanism where typically, you can have asparagine coming in through like your diet. And it's not something that, cancer cells are able to really synthesize on their own. And so what you can see here is that asparaginase can actually then degrade asparagine and turn it into aspartate. And then normally what you'd be able to find is that your normal cells, healthy cells, could convert aspartate back into asparagine. No problem. It can handle that. But with cancer cells, they don't really have that ability to do that. And so you can actually end up depleting asparagine from the cancerous cells, and thus they're not able to use that amino acid. And then you start to kind of lead to cell death from just lack of nutrients, essentially. So again, kind of a novel mechanism, something we see used. We use this a lot for different types of leukemias. If you work in pediatric oncology, you will see a lot of leukemias there, and so we will see something like asparaginase being used quite frequently there. And it makes sense to think of the mechanism. Asparaginase, it's breaking down asparagine, and the cancer cells can't convert aspartate back into asparagine. So, okay. As I mentioned, a lot of acute lymphocytic leukemia, so I use that all the time. And again, you're using it in combination with other stuff like methotrexate, doxorubicin, vincristine. Kind of interesting here, actually the order of the medications actually matters, and this will be indicated on the roadmaps if you were using one of these for your patients, where you're using methotrexate given first, because they actually find that the asparaginase will stop protein synthesis and prevent methotrexate from working. You need methotrexate available to interact with that thymidylate synthase and prevent it from utilizing or inhibit dihydrofolate reductase. Well, that's not going to be working very well if you end up giving the asparaginase first. So the order of medications actually makes a difference there. Again, am I going to ask you that specific point? Probably not. There's other big ticket items I'd rather quiz you on. But again, ordering of medications does actually have some rationale to it. There's some method to the madness in some cases here. In terms of toxicity, you can see here they are can be numerous and sometimes quite serious. So, for instance, like intracranial hemorrhage, you can see pancreatitis, bleeding issues due to depressed clotting factor production, all of that. So again, not a completely benign drug by any means, but very effective for the leukemias that it's effective for. All right. Another way we could try to attack cancer cells would be with what we call immunotherapy. And this is basically where we are trying to take the patient's own immune system and kind of ramp it up to attack these cancerous cells here. Cancer cells tend to be a little less antigenic than foreign cells, but if we can try to pick up the immune system, try to stimulate it, it can then start to attack those foreign cells and then get rid of them, right, through the complement system and all of that. And so here's an example of interferon, and if you are familiar with any treatment for like Hep C, interferon actually comes up quite frequently there as well. There's a few different varieties, so like alpha 2A or alpha 2B, they have their specific use cases there. But interferon basically increases the cytotoxicity of your natural killer cells. Your natural killer cells get ramped up. So it's like if you're going, if they took like a John Wick and you like gave them like even more guns, like you'd be that much more effective. That's kind of what interferon's doing. Or if like you took a normal John Wick and then you killed his dog and then you get actual John Wick, that's what interferon's doing. So try to relate it back to something I'm interested in, movie-wise at least. But you're also going to see the actual phagocytic ability of macrophages is increasing, all of that. So it sounds great, right? It sounds like, okay, we're ramping up our immune system. This has got to be awesome. This is actually like a really awful drug for patients to take. You can see here it's used for a lot of things. So back in the day, before we had newer treatment for Hep C, this was kind of like one of the go-to drugs for that. And you can see this also being used for certain types of leukemia and Kaposi sarcoma, which is something you frequently see like with more late-stage AIDS patients, things like that. And it's a protein, so it's a sub-Q drug they're having to administer multiple times a week, frequently at home by themselves. And you can see here it's a recombinantly formed from E. coli. So again, it's a foreign protein, so anaphylaxis is again going to be a risk with this set of drugs here. But it's all the other stuff that's really awful. You're ramping up your immune system. So imagine you're kind of giving yourself the same reaction you would get if you had like a cold or if you had the flu or something like that. So you're going to see a lot of flu-like symptoms, fevers, chills, myalgia. That means the drug is working, right? Because it's ramping up your own immune system. A lot of CNS effects, though, are actually really problematic, though, that you're going to see with this. So for instance, you can see things like worsening depression. You can see really aggressive behavior. I've talked to some families who one of the family members was receiving interferon for Hep C, and they always hated whenever they got their infusion because they were just kind of a jerk when they were on it because there's very aggressive sort of behavior associated with that. So definitely things you want to watch for. A lot of black box warnings associated with this. Make sure they, if they have depression, they are monitoring for that. Look for new onset depression and all of that. And certainly, like most of the drugs we're talking about here, not good for pregnancy either because it can pass to the fetus. Another one here is called Aldesleukin. This one is actually working with stimulating things like interleukin 2 and T cell growth factor. So again, helping to ramp up the immune system. So it's regulating that proliferation and differentiation, and basically helping to make more immune cells to actually attack these cancerous cells here. Again, you're going to see that with a lot of the cancer drugs we talked about, that cancer was a risk of those drugs, right? Just like with antiarrhythmic drugs, arrhythmia is a risk with those drugs. Same thing can happen here. If you're overstimulating that immune system, there is some risk for secondary cancers that can actually develop. So can be a nasty side effect. And again, that's something you're going to be monitoring for. Again, infusion-related reactions, very common. Anaphylaxis, you're certainly watching out for, all of that. So again, just some examples of indications you may see here. Again, things like lymphoma, colorectal cancer, all of that really is going to be very dependent. And again, if you were to go to work in oncology, you would find sort of what your specific patient population is. So if you work in pediatrics, you're going to be used to a very certain set of drugs. If you go work in adults, you may be used to a very other set of type of medications. If you do mostly colorectal cancers, for instance, you'll get used to those medications there. So again, you're going to probably lose a lot out of this class over time, but again, I want to have you a wide breadth of knowledge. That way, whenever you go into something, you're at least familiar with a lot of these drugs already. As you might imagine, again, ramping up the immune system, you're going to get those flu-like reactions here. Uniquely, though, there's also some other reactions you can see here, like this capillary leak syndrome, where basically your capillaries become, those little gap junctions between cells become larger and allow for more fluid to leak out, which leads to hypotension. And actually, a lot of those patients require pressor therapy. So putting them on things like norepinephrine or dopamine or something like that to get their blood pressure back up. And to go along with that, arrhythmias and MI and heart failure, all these horrible things, right? So again, not a drug you want to use lightly, but when it's indicated, it can be sort of the difference there for that patient, whether they get that cancer under control or not, as the case may be. Again, here, CNS edema associated with that kind of makes sense based on the other side effects we're kind of talking about with there. So very much using caution if patients have history of seizure disorders, have any kind of like pulmonary conditions, cardiac conditions, because it can exacerbate pretty much any of those. And again, patients should really understand, hey, if you're on medications like this, they need to know kind of the benefits versus the risk of utilizing these medications here. And at some point, the patient may be so far progressive that they may say, I just don't want treatment anymore. I just want to go ahead and stop because the medications make me feel so horrible. I'd rather just be comfortable for the rest of the life that I have left. So that's when you're talking about transition to palliative care and things like that. So those are all the medications. Now I want to talk more about sort of the logistics and sort of how we use these medications for treatment of cancer. So we're talking about dosing and administration. As I've kind of alluded to previously, a lot of these regimens are what we call count dependent. You need to give the time for the hematologic system to recover before you attack it again, right? So even if it's something like colorectal cancer, the drugs you're giving frequently are going to be hitting that immune system anyway. So you still got to allow it to recover. You got to be looking at your platelet count. You're looking at your absolute neutrophil count. Remember how you get absolute neutrophil count if you don't have it reported on the lab report. You can just take the percentage that's on that diff and then multiply it by the total white blood cell count. That'll give you basically your absolute neutrophil count. Other things too, renal function, look at things like your urinalysis, hepatic function. Some of these may be more specific depending on the drug you're talking about. So things like, for instance, cyclophosphamide, and looking at the urinalysis for hemorrhagic cystitis, right, as an example. And how we dose these drugs is also really important too. So some of it may be age dependent. Some of it may be weight-based. A lot of it tends to be BSA-based, right? So body surface area, where you're taking into account both the patient's height and the weight. And so you definitely want to watch for that to see, should you adjust patients' doses based on these changes here. In pediatrics, it's changing quite rapidly, as you'll see. But also, sometimes it's hard to get a height on a kid, right? Sometimes it's hard to make sure that they're actually standing up straight long enough for you to actually be able to get an adequate height, so that way you can dose the medications appropriately. So there's some challenges there, but it's something we deal with. Another thing to consider too is that, are these chemotherapy drugs, are they just toxic to your patient? Well, no, they can be toxic to us too as healthcare providers. And so depending on sort of what your role is on the team, you may or may not be close to handling these medications here, but proper PPE is super important here. So it's personal protective equipment, making sure that you're wearing shoe covers, you have gowns on, gloves. If there is any risk for things being aerosolized, make sure you have face and eye protection on as well, because these drugs can be exposed to us, or we can be exposed to the drugs, and they can actually cause secondary cancers for us. Or if you have like a pregnant patient, or I'm sorry, pregnant healthcare provider get exposed, that can cause potentially teratogenesis, right? Matt saying, when my wife worked at a vet clinic, she had to be careful with the chemo for the dogs and cats too. Yeah, exactly. Unfortunately, we don't have any we don't have any drugs just for dog cancer. It can affect us as well, right? They also are probably a lot cheaper for the dogs and cats than they are for humans, as it turns out, for a lot of things. But anywho, you also want to consider too, like the patient excretions can also be toxic, right? We would consider these to be hazardous. And so a lot of it depends on how, like when the last time the medication was given, but that can include blood. They may have to say you're going for blood draws or something, diapers, so like urine can be a potential exposure there. So these are all things you want to be careful of, because you got to take care of yourself. Otherwise you can't take care of your patients, right? In terms of other supportive care, it's really important that we help to help the hematologic system recover in some cases. Sometimes patients will recover on their own. Other times we need to help them out. And so this is where we're going to see that frequently myelosuppression is kind of a dose limiting side effect, right? Sometimes you can't give medication for weeks at a time because you're allowing time for your patient to recover their neutrophil counts. And so, and again, depending on the time frame for the drug, some of them may be delayed to even causing their myelosuppression. So we saw with things like carmustine and lomustine could be like, a couple weeks out before you really see the full nadir of their white cell count. But it's not just white counts. It's not just your platelets that are being affected. The red blood cells can be affected too. It's just they have a longer, they have a longer lifespan, so it takes longer for those things to be noted there. So anemia is certainly something you can also see for these patients. So there are bigger risks for bleeding, bigger risk for anemias, and bigger risk for infections, right? So one of the big things I also want to note here too is that anytime you have a neutropenic patient, you do not want to do any sort of rectal probing, administration, temperatures, anything like that. Suppositories, no nothing, right? And you're like, well, why in the heck does that matter? Why do I want to avoid rectal administration? Well, because if you think about the rectum, it is a relatively thin mucous membrane. If you think about what the cancer drugs are doing to that tissue, it's preventing those really rapidly dividing GI cells from replicating. So that tissue is more friable, right? Not like friable like cheese sticks or something, but friable as in it is very sort of like brittle sort of tissue. It's very easy to break. And so that means that you can accidentally have perforations. And that means you're introducing all of these new bacteria into areas where they should not be, and can cause infection because the patient's immune system is depleted, right? So really, really important to avoid rectal administration. Also too, like, avoid things like fresh fruits and flowers for your patients, because they can be a source for contamination and infection, unless it's something that can be peeled, like a banana or an orange or something like that. Those are okay. So those nice, like big, what do they call them? The edible flower arrangements or something like that, edible creations, whatever they are. Yeah, you can't really like give those to cancer patients who are on active chemotherapy, because all those fruits that have been exposed to the air might be possibly contaminated. Although I think I've seen some pictures of those recently during COVID times. I think they just sent them like in a bag or something. So who knows? But regardless, something to think about more for more normal times. One way we can actually help the patients out is giving them what we call colony stimulating factors. And so these are actually medications that we can administer to help stimulate some of these cell lines to grow more quickly than they would otherwise. So here's an example here where we could actually give erythropoietin. We have synthetic forms of erythropoietin we can administer to patients to have them produce more of their own red blood cells. Or for instance, we can give things like colony stimulating factors for your granulocytes. All these different things. So things to consider. Sometimes you'll see these being given, not in every single case there, but they can be useful to help replace cell counts that are taking kind of too long on their own. Yeah, so that may be exactly why they prohibit those flower deliveries there for sure. All right, other supportive cares that's important includes GI care, right? So nausea, vomiting is super, super common for these patients here, especially depending on the medication they're getting. We will talk more about antiemetics in the GI section next semester, so I'm not going to be quizzing you on those drugs specifically, but some other things I want you to think about include like the mucositis. Very, very painful oral ulcers that they can develop, oral pharyngeal ulcers that may prevent them from eating and drinking sufficiently. right? So again, they're miserable. They're receiving chemos making them throw up all the time, and now they got these ulcers. They don't want to eat. They don't want to drink. Again, that's not going to be great for their immune cell counts, right? Can promote infection, all of that. So this is why oral hygiene is really important for these patients. So using things like salt rinses can help. And then here's a drug here called chlorhexidine, which is an antiseptic agent that we can use to sort of either swish and spit, or there's like little swabs you can use to make sure to keep the mouth clean. Because I don't know if you know this, but people's mouths are generally pretty dirty. So keep that stuff clean so you don't get secondary infections there. Just to give you an idea of the emetogenic potential of some of these anti-neoplastic agents here. And again, I'm not going to quiz you specifically to say which one of these are highly emetogenic versus not. Just know they're all going to cause nausea and vomiting, but to varying degrees. So if I have a patient who's going to be getting something like cisplatin, that's a greater than 90% frequency of vomiting without antiemetics. That's almost guaranteed. That's very good odds they're going to throw up. Again, not great for the patient from their quality of life standpoint. And it can go down from there depending on the drug you're dealing with. But just to give you an idea of how poisonous these anti-cancer drugs are, I mean, like we even give people arsenic. Like, you know, arsenic is like trying to poison your significant other or something to get their insurance money, but we give this to people to treat their actual cancer, right? So very, very important to make sure that we cover them with antiemetic drugs. We'll talk again about those next semester. From a skin standpoint, we don't really have any good pharmacotherapy for their alopecia. It just kind of goes part and parcel with certain medications that tend to be worse than others. Kind of interesting too, like sometimes their hair will grow back at like different sort of like different textures almost. But again, no good pharmacotherapy. See, and you think, well, let's give Rogaine. Why wouldn't that work here? Well, the issue is not necessarily that the blood flow is not going to the scalp like you would see with like a Rogaine. The issue is that you're inhibiting those cells from dividing essentially. So the follicles are not being able to rapidly divide like they normally do, and that's what the issue is. So there's no way to stimulate that. There's no like hair growth colony factors or something like that we would, or colony stimulating factors that we would use. So just kind of goes part and parcel with it. And then I mentioned the extravasation, so you gotta be really careful here with drugs that extravasate out of the vein, right? So I mentioned this is where like someone has a peripheral vein, peripheral catheter placed, and the vein blows, or you have some kind of infusion into the subcutaneous tissue, can lead to infections, can lead to tissue destruction, can lead to scarring, amputations in some cases. We gotta be really careful there. So things like the taxanes, the vinca alkaloids, and the anthracyclines are really bad for this. And so every hospital you go to will likely have a extravasation guideline that will tell you how to manage that. So I'm not going to get into the details here, but it's very important that we be able to deal with that, whether it's hot compresses, cold compresses. Sometimes we even use an enzyme called hyaluronidase, which is basically, it breaks down some of the subdermal connective tissue that allows it to be absorbed more quickly. Because the faster you get it absorbed to the systemic circulation, the less damage it's doing there in the tissue itself. Shelby's saying I had a patient that had gray hair and it grew back dark without the gray. Very interesting. Yeah, so all kinds of wild stuff happens with the hair after receiving chemotherapy. So that's it for this section. Do you guys have any questions so far? Let's see. Someone says, do you want us to know the mechanisms of the MAB medications? I would know the mechanisms in terms of what specific target it's going against. So if it's going against CD20 or CD52, all of that, I would at least be familiar with that. In terms of the mechanisms, because that is important. That does differentiate them from one another. You can't just say, oh, it's a monoclonal antibody. Well, we have monoclonal antibodies for everything from developing some for COVID to stuff for rheumatoid arthritis, for cancer. So there's a lot of, it's kind of a very broad kind of categorization there. So sorry to disappoint you. Any other questions before we get moving on to the Kahoot? All right, so let us do our classic. Make sure it's going to randomize stuff. And I will post the video for this, and I'll post the post the Kahoot up after as well, so you guys will have access to this to go check it out. Oh my goodness. I was making music, but the site is muted. There we go. That's better. Some people like the music. I don't really like it much, but we got our spoopy ghost here. Can you guys see the stuff? So Matt was saying, how long does the EPO take to get anemia corrected? That's a good question. It does take some time. There usually is at least a few weeks to a month or two lag time in order to actually get that stimulated. Remember too, with and we'll talk about this in the renal section next semester. In order for EPO to work, you got to make sure patients are stocked up on the other precursors for red blood cell production. Their iron has to be in place, thiamine, folic acid, all that good stuff has to be good to go. Otherwise, you're going to be giving them a really expensive drug that's not going to do anything. So that's frequently what we see with a lot of renal patients, like dialysis patients and stuff that receive epoetin for that, is that if their iron isn't under control, then the drug just doesn't work. So that's an important bit there. All right. Personally going for the lizard people. Make it happen. 40 in so far. Let's see. I was Walking Dead, and they tried giving EPO when someone was actively bleeding out. Oh, was that on The Walking Dead? That seems very silly. I would not waste epoetin on someone who's actively bleeding. I'd be like, give them blood. Stop the bleeding and then give them blood. That's important. All right. Well, it looks like I got 48 of you in. I'll keep the pen up there so you should be able to continue seeing that if you want to get in later. Would fail now. You will not. Would fail never. How about that? We can get started in the interest of time. Blabbing at you guys enough. All right, so which medication do you think would provide mortality benefit for CHF patients? Would it be furosemide, acetazolamide, hydrochlorothiazide, or spironolactone? What do y'all think? Ah, very good. This is a classic folly of PA students. So remember, when you're looking at your drugs for CHF, not everything is providing mortality benefits, right? So just because someone's receiving Lasix, which is a loop diuretic, doesn't mean that they're going to be living any longer because of that. Now, can it prevent them maybe from ending up in the hospital because they're fluid overloaded and it's accumulating in the lungs? Perhaps, but at least when you're doing the long-term studies, they don't see necessarily any mortality benefit. So again, symptom management is really what the loops are going to be used for. HCTZ can be used in these patients here, but it's mostly more for blood pressure management than anything. Sometimes you will get patients get what they call loop resistance, where they can actually end up developing their diuretic effects of the loop will become sort of attenuated a bit because the distal convoluted tubule is trying to pick up the slack and absorb more salt and water. So what we can do for those cases there is actually give a loop plus a thiazide, and you'll end up seeing that urine output actually pick up because of that. So it's something you may see occasionally. Diamox not really have any indication for CHF specifically, but spironolactone absolutely does have some benefits for our patients here. So, but remember, it's more for late stage patients, so 3 and 4 grade CHF, and also remember who you do not want to use that in. So if they have, like, their serum creatinine's above 2.5, if their potassium's above 5, you don't want to use it for them because their creatinine's high, probably means they have poor kidneys, which means their potassium is more likely to be high anyway. And then they're already hyperkalemic. You don't want to give this because what's that going to do to their potassium? It's going to raise it even further, right? So don't want to do that. So good for mortality benefits, but again, be selective in who you're going to use it for. All right. Trexate's in the lead. Which of the following would be a reasonable treatment for rate control of atrial fibrillation? Use nitroglycerin, adenosine, lidocaine, or diltiazem? Very good. Yeah. So again, go back to your mechanisms for the drugs and how they're working, and that will make a pretty good sense. So if I have someone who's an AFib, say they're regularly an AFib, and I give them the diltiazem, it doesn't really fix the atrial arrhythmia. It just prevents that rapid signal from being sent down to the ventricles. So that'd be an example of rate control there. On the other hand, if I wanted to say do something like a chemical cardioversion and put them back into normal sinus rhythm, I would need something else for that. So really none of the drugs on this list would do that necessarily. Remember, lidocaine's really better for like ischemic tissue that's having conduction issues, so like an MI, and it's more for ventricular arrhythmias, but something like amiodarone, something like procainamide, something else like that is going to be more likely to work directly on the atria to actually fix that rhythm issue. All right. So after failing OTC benzoyl peroxide, which medication would next be indicated for facial acne? Just on the face, would I use doxycycline, hydrocortisone, adapalene, or lithium? I have any Nirvana fans out there? But we will not use lithium for these patients, though. But why did I put lithium on there? Anyone know? Periodic element has a brand name. Yeah, when you put it into an actual drug dosage form, yeah, absolutely. So yeah, it actually causes it. That's another common cause for drug-induced acne there. So remember, okay, so they just use benzoyl peroxide. And frequently, like this is when you're going to see these patients too. So like if you're working in your derm office or maybe family practice or something, they're going to come in and be like, man, this acne is terrible. I've been trying to use this over-the-counter stuff. It just doesn't work. Question is like, what do you go to next? And again, if it's mostly limited in terms of exposure, if it's just to the face, then you can get away with using something like adapalene, which is going to be a retinoid, right? That's perfectly reasonable to move up to that. You don't necessarily have to go with oral antibiotics unless it's kind of more diffuse, maybe covering the oh, very good. Yeah, so the 0.1% OTC as well. I think that's pretty recent too, in the past couple of years, I believe. But yeah, so again, ask what they've used. That's a very great point to make there, is ask what they've used, what's worked for them, what hasn't, and then you can kind of figure out where to go from there, right? Obviously, hydrocortisone, that would make it worse. So, all right. Application of corticosteroids to which area would most likely lead to systemic effects? The soles of the feet, the axilla, the forearms, or the hands? I had a diabetic patient one time who had a bilateral below the knee amputations. He had no sole. That was a bad joke. Yes, so the axilla. Remember those intertriginous areas. This is great because at least I get like the text replies. I normally get to hear the groans in person during normal times, but yeah. So intertriginous areas of thin skin are more likely to see that absorption. So groin, axilla, the face, places like that is where you want to be cautious. Remember, using lower grade steroids for those areas as opposed to areas of thicker skin. You can get away with using more potent steroids or higher percentages there, right? So very good. Which of the following will provide coverage against Legionella? So we're going back to our pulmonary stuff here. We do cefazolin, moxifloxacin, azithromycin, or clindamycin. All right, so there's actually two correct answers here. Good. So you always want to think about what your options are when you are going to treat a patient, right? Because if your game plan A does not work, then you got to know what your plan B is going to be in those cases there. So things like clindamycin, things like cefazolin, they're not really going to be covering those atypical pathogens like Legionella, but something like a fluoroquinolone, something like a macrolide will cover that. Now, again, if I had my pick, depending on things go, I'd probably pick azithromycin. most likely as a first line, and use Moxie as a backup. But again, it may depend on if the patient has allergy or something like that. But either one would technically work. Again, on the test, I'll only give you one right answer as long as I can help it. Which of the following medications is it safe to smoke with? You'd smoke with no drugs, but if you had to smoke with a drug, which one could you do it with? Varenicline, nicotine gum, bupropion, or albuterol? You think? Well, there's also multiple answers here, so good job those of you who picked one of these three. You had a very good chance of getting that correct. So think about the mechanisms here, right? So remember that when you're using something like Nicorette gum, which is just nicotine, right? It is trying to replace what the patient's missing when they stop smoking. So if they continue to smoke on top of taking the nicotine gum, their overall dose of nicotine has increased now, which means they're probably getting more than what they're used to, which means toxicity is more likely. And so they can get a lot of like CNS effects, tremulousness, things like that. Those are things we obviously want to avoid. And if anything, we're trying to reduce their dose over time and not increase it. On the other hand, though, things like varenicline or Chantix, remember that is occupying those nicotine receptors. It's only partial agonists. So even if you smoked on top of that, there's going to be competition there for the sites, and so the nicotine's not going to be as effective. So it would be okay. And in fact, remember how we started Chantix? You basically start the Chantix 1 week before your quit date, and then you can take both at the same time, and then you stop the smoking, and then let the Chantix kind of do its thing on its own. So that's perfectly safe to do. Bupropion, no direct effects on nicotine. If anything, it's more affecting dopamine, a little bit of norepinephrine, but no effects on nicotine specifically. And then patients who do smoke, they might need some albuterol because of all the irritation that the stuff is going to cause on them anyway, but no direct interactions there. All right. I would choose the gum. I don't know. Hopefully I've never started smoking, so I don't know what the best way to quit would be, for me at least. For arrhythmias, beta blockers are considered rhythm or rate control. Kind of covered this a little bit, but let's see if you know it. Very good. Remember, just like with the non-dihydropyridine calcium channel blockers, this is slowing down AV nodal conduction, right? So you're decreasing the rate of those really rapid beats coming from the atria being sent down to the ventricles. So this is why these are used for rate control. The atria can still be sitting there quivering away. Doesn't really matter because the ventricles are pumping at a relatively normal rate there. Not fixing the rhythm, rate control, right? Don't forget to tell you about my tox case I had last night if I get to the end and forget about it. Which medication would be appropriate for coverage against Pseudomonas and ventilator-associated pneumonias? Do I want to use levofloxacin, ceftriaxone, vancomycin, or piperacillin tazobactam? Now, this is like stuff from the first test, but it comes up again here for the specific indications, right? So, gotta know your antibiotic coverages. Very good. Again, 2 right answers here, which is, again, not going to be on the test. So think about pseudomonal coverage. Remember, you have your anti-pseudomonal penicillins. That's just piperacillin tazobactam we talked about. Anti-pseudomonal cephalosporin, so things like cefepime primarily. Ceftazidime a little bit, but we don't use that clinically for that indication typically. Think about your fluoroquinolones. Namely, like levofloxacin is probably the more common one we see with consistent coverage against Pseudomonas. And then we have our aminoglycosides. Those are the 4 big groups there that I would say those are like your go-to Pseudomonal coverages, right? And remember, if you needed to treat Pseudomonas for ventilator-associated pneumonias, you're double covering. So would it make sense to combine levofloxacin plus piperacillin tazobactam? What do you guys think? Quick yes or no?
Yes.
Why yes?
Oh, no.
You spoke up, so now you got to say something. I tricked you, ha!
I'm not sure.
That's okay. Anyone else have an idea? Bamboozled, yes.
isn't piperacillin tazobactam, that's already like double coverage anyways for it. Like,
Not
and that's the big boy.
It's a big boy for sure, but think about so remember the mechanisms. Go back to the mechanisms if you're not sure. So recall how piperacillin's working. Remember, it's a beta-lactam antibiotic, right? You don't want to use two beta-lactams together, so it wouldn't make sense to put piperacillin plus cefepime. However, if I can use two different mechanisms like levofloxacin, which is a topoisomerase inhibitor, plus a beta-lactam drug, now I got something working on the DNA and I got something working on the cell wall. They work better together, right? And so being able to recognize what an appropriate regimen is very important, because that could be a medical error you catch, right? You could see someone who's on piperacillin and cefepime, and that would be a big red flag when you're looking at it, because you're like, well, why would they need both? There's very rarely an instance, I can't even think of one where you need both there. So things to consider too. So like, could I do levofloxacin plus an aminoglycoside? Well, yeah, they both have different mechanisms. That does make sense to combine the two there. Okay. So now going back to what you were talking about with piperacillin plus tazobactam, it's a big boy because it does have the beta-lactamase inhibitor there with it. But remember, that doesn't necessarily have any antibiotic activity itself. It just prevents beta-lactamase from working. Okay. So it helps the piperacillin to work better, but it doesn't necessarily replace the double coverage that we need with something like levofloxacin. That makes sense. Okay. All right. So which may have the fastest onset of action for treating all symptoms of anaphylaxis? We gave someone some Rituximab and they're having full-on anaphylaxis. They can't breathe, throat swelling up, they're hypotensive. You give them epinephrine, sodium chloride, diphenhydramine, or methylprednisolone. Now, clinically, are multiple things happening in parallel? Absolutely. But just to think, if you were the only person there and you had to pick the first drug to give that patient, what would you give them? Epinephrine, very good, right? Because again, epi is going to be the thing that's going to treat all those symptoms there. It's going to hit those alpha receptors, beta receptors. It's going to allow the smooth muscle in the lungs to open up. It's going to clamp down on the blood vessels. It does everything, right? Very good, very important. That's why if someone has a history of anaphylaxis, what do they carry with them? An EpiPen, right? So it's because it works so effectively and very quickly. Now, NS would also be given. Obviously, that would help to treat the cardiovascular symptoms of hypotension, tachycardia. We do that. Benadryl, very effective, helping out with the the histamine, but doesn't necessarily treat. It doesn't necessarily going to fix the blood pressure right away like Epi would. And then methylprednisolone we know to be relatively slow acting, maybe a few hours, as opposed to something like Epi, which is going to be like that. Okay. So very important to make sure if you had to give one thing first, that would be it. All right. So which controller medication is used in COPD but not asthma? Want to use tiotropium, beclomethasone, albuterol, or ipratropium? It's a controller medication used for COPD but not for asthma. All right. Right. So remember what our different options are available here for patients who are being treated for COPD versus asthma. Could there be both concomitantly? For sure. But let's just keep the two separated right now. Recall that we don't really focus a lot on anticholinergics for asthmatic patients. Sometimes we use ipratropium. It's a short-acting anticholinergic plus albuterol, but rarely, if ever, or ever, would you use an anticholinergic by itself for an asthmatic patient. We do that for COPD patients, right? So that's kind of one of the big differences there. You don't use tiotropium for asthma, you do use it for COPD. Now, beclomethasone, a steroid, you can use it for both, absolutely. Albuterol, ipratropium, those both are not controller medications, right? Those are fast-acting medications used to treat an acute exacerbation of their COPD or their asthma, right? So keep in mind what the drugs are being used for and how they're used differently between the two conditions, right? So there are some slight differences there, and you should be able to pick out those points of articulation there. All right. So for arrhythmias, flecainide or Tambicort is considered rhythm or rate control. What do you think? Very good. Remember, so flecainide being what class of antiarrhythmic? Okay, you got to think of its mechanism. Okay, it's a sodium channel blocker, so I know it's a class 1 antiarrhythmic. Is it class 1A? Is it PDQ? Nope, it's not PDQ. Is it class 2 or class 1B, I should say? It's not lidocaine, so class 1C. It's got to be one of those two. So flecainide, propafenone, those are your 1Cs. And again, those are going to be working more on the rhythm control. That's something you could use. And again, that's one of those drugs you could use as a pill in a pocket, so to speak, where you could give it if the patient feels like they're going into AFib. And frequently they can. They kind of know when they're going into it. So you could use that on a more PRN basis. It's not recommended typically. That's why you see a lot of those patients just on beta blockers. However, that is sort of an older way to do that. Advice and never to prescribe 1Cs ever. There are that is generally good advice. There may be some instances here where it is indicated. So for instance, if again, if you are dealing with patients like certain cardiac conditions, like a congenital condition or something, or if they have open heart surgery, there are some instances where it is used, but again, it's not common. However, you may not be the one prescribing it, but you may see people who are on it, and you still need to be able to identify what it is, right? So in case they do have an issue of an arrhythmia, you can say, oh yeah, it could be due to this drug. All right. Which of the following inhibit DNA synthesis by acting like false nucleotides? It would be docetaxel, methotrexate, cytarabine, or etoposide. Never feel afraid if you hear there's like there's contradictory information being given by your professors. Like, bring that stuff up. You know, we like to hear that stuff so we can kind of talk about it, because frequently there are different perspectives that we have on things, and so it's not that they're contradictory. It's just it depends on the situation. So I like to hear that kind of stuff. I can at least look something up if I need to, or be able to clarify. Very good. So going through and knowing the mechanisms are important here. And again, using synergistic mechanisms together does make sense. That's why I wouldn't use something like vinblastine and vincristine together, because they do the same thing essentially. But using different mechanisms is helpful to treat these cancers. Remember, docetaxel, it's a taxane, so it's working on the microtubules. Methotrexate is more of a folic acid antagonist, right? So that wouldn't really, it decreases synthesis of nucleotides, but doesn't act as a replacement for them. And then etoposide is a topoisomerase inhibitor, right? So really cytarabine, Ara-C, and again, you think, cytidine, cytarabine, they kind of sound similar. That's where it works, right? So it's a false nucleotide. It gets incorporated into the DNA, and then it's a chain terminator. Can't add on anything else to it. That's one how that's working there. So go back, know your mechanisms for the drugs. It's certainly important. All right, so which antidote and drug combination is correct? Folinic acid and methotrexate, acrolein and cyclophosphamide, dexrazoxane and vincristine, or mesna and cisplatin? Interesting, almost a pretty even split there amongst the other ones. So let's go through that. So remember, methotrexate is a folic acid antagonist. So you can't give someone methotrexate and then give them folic acid to fix anything. You will see it sometimes concomitantly prescribed because it's not going to hurt, right? You know, folic acid is a water-soluble vitamin. You know, get a little bit extra. It's not going to hurt anything, right? Maybe it will help out some of the healthy cells. But in order to stave off the direct effects of methotrexate, you have to give the activated form of folic acid, which is folinic acid or leucovorin. I'll never forget one time I had the fellow who's a year ahead of me. So I was the first year, he was the second year. He had a consult on the phone, and a patient had accidentally overdosed on methotrexate. They were given it at home for themselves for rheumatoid arthritis, and accidentally given like a tenfold overdose or something. He called up and said, okay, let's go ahead and give this much folic acid. And he hung up the phone, and he's like, I said folic acid, didn't I? And I go, you said folic acid. You should probably call him back. And he's like, crap. And so I had to call him back. And it's awful when you have to call back and go with your tail between your legs to correct yourself, but it is what it is. So that would be a correct combination. Remember, cyclophosphamide produces acrolein. That's what causes the hemorrhagic cystitis. Okay, so that's the actual toxic byproduct there. Mesna would be the antidote for that, right? So you give mesna along with cyclophosphamide in order to prevent that toxicity from occurring there. Cisplatin, no real antidote for that one, unfortunately, besides just really vigorous hydration. And then dexrazoxane is going to be for your anthracyclines, so your doxorubicin, daunorubicin, and mitoxantrone. Okay, no good antidotes for vincristine, unfortunately. All right. So you're concerned for MRSA pneumonia in a patient. Which antibiotic would cover this? You have dicloxacillin, azithromycin, linezolid, or daptomycin. Very good. So I bamboozled a few people here. So remember dicloxacillin, not good for MRSA, but good for MSSA. So one could be used for that. Azithromycin's not going to have any coverage here. The tricky part here, which obviously I did not trick a lot of you, was with the daptomycin. Does daptomycin cover MRSA? Yes, it does. Does it work in the lungs? No, it does not, right? Surfactant in the lungs actually disrupts the daptomycin, does not work for pneumonias. You can use it for cellulitis, you can use it for osteo, you can use it for bacteremia, cannot use it for lung infections. Linezolid, though, does work very well. It got good penetration, no renal dose adjustment. It's awesome, except for it's very expensive. And you want to hold off on using it. Obviously, our first line would be vancomycin, 95 times out of 100. You'd be using that over something like Zyvox. Which medication has the slowest onset of action when treating chronic, or for the chronic treatment of asthma? Be albuterol, mometasone, omalizumab, or theophylline. The slowest onset of action. Very good. So think about the mechanisms for how these drugs work. So obviously with albuterol, that's for quick acting treatment, not really used for chronic management for asthma there. But think about omalizumab, right? It's a antibody targeted against IgE. So the second you inject it, it's going to start to bind up that IgE, and actually the onset's going to be fairly quick, right? So it's going to be able to bind that up and then neutralize those antibodies. So relatively quick onset of action, just not used frequently because it's, you know, carries a lot of risk, a lot of cost with it. So it's more of a last line sort of agent there. And if you find a patient who's being treated chronically for asthma with theophylline, their provider probably graduated like med school in the Cretaceous period or something. Like, you're just not going to find a lot of newer school providers that are going to use theophylline for asthmatic patients. It's just too narrow therapeutic of an index. It's just we don't have a lot of good reason to use it when we have things like our inhaled corticosteroids that tend to be very efficacious for these patients here. So mometasone, remember the point with mometasone and other inhaled corticosteroids is that they do take time to work. They can take up to several weeks before you really see maximal effect. As opposed to if you were to get like a systemic corticosteroid like prednisone orally, that would kick in within a couple hours, just the nature of the drugs here. So they need to make sure that they're taking it consistently and realize they may not have symptomatic benefit for at least a couple of weeks. Now, what could I do to speed that up? Well, I could actually give a combination of a long-acting beta agonist plus mometasone. So something like formoterol plus mometasone, I think that's the combo. I think about salmeterol and fluticasone or Advair. That one is going to give you the initial benefits of a beta-2 agonist. And then over a couple of weeks, then you'll have the additional benefit of the inhaled corticosteroid. Okay, so just keep in mind how these drugs are working in terms of like when patients should expect to see symptomatic relief and all that. Advair is not in the UK only. That is for us here in the US at least. I'm not sure what's available in the UK. It's salbutamol that is the UK name for albuterol, but that's as far as I know. Unless I took it out of the US, I'm not aware of that. All right, which of the following medications have mortality benefits in CHF patients? Kind of similar as before. Lisinopril, candesartan, enalapril, or irbesartan? Yes, all 4 are correct. All of them carry mortality benefits for your patients there. If a patient has CHF, they need to be on some sort of ACE inhibition or some sort of angiotensin 2 inhibition, right? So either an ACE inhibitor, if they can't tolerate that, an ARB is perfectly fine. Probably not as wide of a breadth of evidence behind its use, but again, it's expected to have the same benefit. Again, it's mandatory. Again, what does it do for us? It's going to help us with that remodeling of the left ventricle. It's going to slow that down. It's not going to reverse anything, but we'll slow it down and help us out from that standpoint. Matt's saying enalapril has a short half-life. Would that not be as good? Or is that captopril? That would be captopril, is typically the one with the really short half-life. Enalapril can be used perfectly fine. The IV form we do have is actually enalaprilat, but no, it would work totally fine there. And again, you could get around short-acting meds by giving them more frequently, but from a patient compliance standpoint, these guys are going to be a lot of meds anyway. So if you can try to keep it simple as you can, that's reasonable. So longer-acting meds like lisinopril, candesartan, those are all fine there. So yeah, need to be on some sort of ACE inhibition. Which of the following agents is cell cycle specific? What is he? Temozolomide, carmustine, cyclophosphamide, or vinblastine? If you can reason out the mechanism, then you should be able to kind of determine, is it cell cycle specific or not. Got some of you guys on this one. So let's look, kind of think through how these drugs are working here. So with something like vinblastine, like why is that cell cycle specific? Well, if you think about the mechanism, well, it's inhibiting the microtubules from actually forming to complete mitosis. If you just have all those chromosomes just lined up down the middle of the cell, they never get pulled apart to actually form 2 new cells, then yeah, that's affecting mitosis. That's very cell cycle specific. It doesn't work unless the cell is undergoing mitosis. On the other hand, though, all of the rest of these 3 here are all alkylating agents. Carmustine, temozolomide, cyclophosphamide, cisplatin could have been on here. All of those are alkylators. They can go directly to the DNA. They can bind up those strands to cause, interstrand breaks, intrastrand breaks, all that good stuff to destroy that DNA to the point where it's so damaged that it says, okay, well, let's just do apoptosis. Go ahead and get rid of the cell. So that can be done at any point. And again, it kind of leads you to think why these other drugs are so toxic, because they can affect all of your other cells that are normally kind of just at a resting state anyway. So that's why you see the toxicity profile being pretty miserable for the alkylators versus something that might be more specific, like vinblastine, for instance. Not to say vinblastine is a good safety profile, but it does not carry the same sort of risk for things like the pulmonary fibrosis and things like that, like you would see with an alkylator. So if that makes some sense. So be able to kind of determine like where is it working in the cell cycle. There's a whole picture that just spoke directly about that too. You can go back to. Which chemo agent could lead to osteoporosis in female patients with breast cancer? The exemestane, raloxifene, flutamide, or doxorubicin? Very good. So remember how the drug's working, right? So think about why something like osteoporosis might happen in a female patient, right? So what is the typical cause for that? Well, typically being postmenopausal, right? They're not producing estrogen themselves. And again, we're going to get way more into detail in this next semester, but if they're not producing hormones themselves, like estrogen, then that's what leads to the osteoporosis. So with something like exemestane that's inhibiting that aromatase enzyme, it's preventing things like testosterone from being converted into estrogen, and then that can affect the bone, right? So that's why osteoporosis is so much bigger risk with something like that than something like raloxifene. Like raloxifene is going to be a selective estrogen receptor modulator, meaning that for the bone, it's actually working as an agonist. So that's good for osteoporosis, but in the breast tissue, it'll act as an antagonist, because even though it's affecting an estrogen receptor, there are some different flavors of receptors depending on the tissue you're dealing with. And the bone is going to be a little different than you would see with the breast tissue. Flutamide is more so for like an androgen receptor antagonist. And then doxorubicin really doesn't have any direct effects on the bones necessarily. However, we want to think about the main toxicity of our anthracyclines. It's going to be the heart, right? The cardiomyopathies you can see associated with that. Got to check your echoes. Remember the max lifetime dose because of the cardiotoxicity. So you got to be watchful for that stuff. Which patient would be contraindicated from receiving alteplase or TPA? That had a serious GI bleed 6 months ago. They have a blood pressure of 190 over 110. They are a pregnant patient, or they have a shellfish allergy. They refuse to share with other people. It gives them the hives. Sorry, it's a selfish allergy. My bad. They don't like telling jokes in the middle of these questions because they can't tell if you're just focused on the question and you're too busy to not to laugh at the jokes, or they're just that not funny. So I'm just going to assume they're just not that funny. So okay, so knowing contraindications for TPA is very important because if you get this to the wrong patient, you very well may kill them, right? So, and I apologize for my getting mushy mouth towards the end of the day here. I've been interviewing all day, so I've been blabbing a lot. So remember, the blood pressure thing is really important. If they have that diastolic pressure over 100, that's not a great sign. Again, the pressure is already really high. If you decrease the integrity of those vessels at all, bleeding is a very high risk, right? Pregnant patients as well are absolute contraindications. Now, the serious GI bleed, again, some of these are a little bit more specific. So for instance, with the serious GI bleed, that was actually within 3 months, right? But on the other hand, if it was something like a cerebral vascular accident or like intracranial growth, then that's really at any point. So some of them are a little bit more time specific. The only reason I'm focusing on it now is because, again, I want you to be able to think about these things. So even if you knew for the test on Monday and then you kind of forgot it right afterwards, which I understand that happens. But if you were to be on clinicals and you were to say, someone's about to get TPA, you'd be like, okay, so they haven't any GI bleeds. What was the time for it? You can at least look it up, but you'd probably at least know that GI bleeds would be a contraindication, at least within some time frame. So again, some of these things are just trying to put it in the back of your mind so you'll be able to pull them out later on down the road here. But you definitely should know them for the test, though. All right, which antiarrhythmic association is correct? What did I say? Class 3 in magnesium, class 1B in lidocaine, class 2 dofetilide, class 4 nicardipine. Rachel, don't worry about writing down my jokes. I will have a book coming out this summer. Just you wait. It's called Laughter is the Best Medicine, unless you have lupus. Right, so class 1B lidocaine, I kind of gave that one away a little bit earlier today. But remember to be able to make the associations there in terms of like their mechanism, and that will help you fit into the category. So obviously magnesium doesn't really fit into one of these classifications. It was more of a miscellaneous sort of antiarrhythmic. Obviously we all know, if I were to say this, if we were all face to face, I'd say magnesium is 4. You'd all say torsades, right? Dofetilide, again, that's a potassium efflux pump inhibitor, right? So it's blocking those potassium channels from effluxing potassium. You are prolonging the repolarization period. That's a class 3, right? Or class 2 are your beta blockers. Now, class 4, this one's a little bit tricky because I said, well, class 4 is calcium channel blockers, but not all of them, remember? It's just the non-dihydropyridines. So nicardipine is a dihydropyridine, would not count as one of your class 4 antiarrhythmics. You would not use that for an arrhythmia. Okay. All right. Which medication is appropriate for an acute asthma exacerbation? What do you use? Salmeterol, ipratropium, fluticasone, or montelukast? All right. So again, remember lumping these drugs into their respective categories in terms of like how they're working, how long they take to work, etc. Remember, salmeterol is not going to be good for an acute asthma attack because it's a long-acting beta agonist. It's better for working throughout the day, but it's not going to be good to treat an acute asthma attack because the onset is going to be much slower than you would see with something like albuterol or even levalbuterol for that matter. We talked about the fluticasone, the other inhaled corticosteroids being taking weeks to work, so obviously that would not be very appropriate for the acute asthma exacerbation. Now, if I put something like prednisone, you could argue that. You could say, yeah, it'd be reasonable to use for a severe asthma exacerbation, more like moderate to severe. And then montelukast, again, that's a more of a controller medication, not going to be good for an acute sort of reaction there. But ipratropium, while not typically the first thing you think about as being used to treat an acute asthma attack, maybe on the outpatient side, certainly on the inpatient side, you'll see that quite frequently. So it's not uncommon. You'll get the order, or you'll order this in the ER. We'll say, okay, let's do albuterol, 2.5 milligrams, ipratropium, 500 micrograms times 3 Q15 minutes, or Q15 minutes times 3 doses, right? It's a very common combination because you get the benefit of a beta 2 agonist plus an anticholinergic to help really open up that bronchial smooth muscle. So it's a common thing you'll see there. Which of the following is not a common side effect of methotrexate? Of course, I don't like not questions, but I'll use them here because I have limited text space. But the leukopenia, hirsutism, diarrhea, or renal dysfunction? All right, yeah, so hirsutism, not a common side effect you'd expect to see with a lot of your chemotherapy drugs, maybe with the exception of something like an aromatase inhibitor, perhaps, like exemestane or something. If you were blocking conversion of testosterone to estrogen, then I could see that maybe causing some hair growth there for your female patients. But the other things are relatively common. So things like the leukopenia, the renal dysfunction. Remember how we prevent that renal dysfunction? We make sure we give them plenty of fluids, and we also alkalize that urine. Make sure the urine pH is above, probably 7.5 to 8, somewhere around there is pretty reasonable. And diarrhea. Diarrhea is common with a lot of these drugs because again, you're killing off a lot of those rapidly dividing GI cells and they can't regulate water absorption effectively in the colon. You're going to see diarrhea. So that's another common thing you'll see with those patients there. All right. Why are some chemo regimens considered to be count dependent? It should be easy. We just talked about it. Because the patient's immune system needs time to recover. Tests for neuro impairment. Boy, I don't even know how I wrote that one. You have to have the patient count to 100 for neuro impairment to test that. There need to be sufficient cancer cells for chemo to work, or hospitals need to wait for enough patient appointments to make a profit. Be having. That's probably one of my prouder academic moments. I didn't say I was coherent when I wrote these things. Okay. All right, yeah, the patient's immune system needs time to recover. This is just re-illustrating the point here. Again, most of these drugs are going to cause some degree of leukopenia. Platelet, thrombocytopenia can happen here, so you got to give them time to recover. Otherwise, they're going to get too big of a risk for bleeding, too big of a risk for infection, so it's not going to be good. And so you have patients who will come in to the infusion center. They made the appointment, they come in, and if their white counts didn't make counts, then they just get sent home, right? They can't give them the chemotherapy. So sometimes it's a whole wasted appointment just getting those labs done, which is kind of a bummer for them. But, sometimes you can't predict who's going to recover and who's not during a certain time period. Okay. And then let's see, which test should be ordered before starting tazarotene in a 26-year-old female? CBC, urine drug screen, urine HCG, or LFT? Very good. Yeah. So remember, any of the retinoids, whether it be systemic or topical, you want to consider getting, especially, adapalene probably is a little bit more on the minor side of things. I would still make sure they're using protection and things like that. But the Zeratine being a little more on the hardcore side of things. Checking for pregnancy is important for these because you, again, don't want to mess with fat-soluble vitamins in patients who may be pregnant, right? Because, again, that can really cause big harm to the fetus. So I do the whole iPledge program with isotretinoin. Again, very intensive. Obviously, much bigger risk with systemic retinoids than topical, but still a consideration to make, I think. Okay. The last question here, which dosage form would be most occlusive when administered topically? A lotion, an ointment, a gel, or a cream? All right, very good. Right, so remember, ointments have a lot better staying power. Remember, their oil content is higher, usually like an oil and a water and oil emulsion. So the oil content is high, so it sticks around for longer on the skin. Just like if you put some Vaseline on your skin or something like that, it sticks around for a while. So it's considered to be more occlusive than something like more water-based, like a lotion or a cream or something like that, that is easier to wash away, can evaporate to some degree. So ointments tend to be most occlusive. So that makes sense. All right, so who's our winner here? Number 3, we have Ghost. Maybe Boo Boo. Go with that. Matt, number 2, and then we have here MTX. Who's MTX? Anyone? Isabel. All right, good job. Good job to all of you. I think you're all winners in my heart for sure. So any questions before the test? Only 20 more correct. Oh, Paige, that's okay. We'll get them all right on the exam. I'm assuming Matt was Matt, right? Perhaps. We all get A's on the exam in your heart too. Yeah, but unfortunately my heart does not export to Canvas, so it doesn't really do a whole lot of good, unfortunately. I give you your free answer, but you guys already know what it's going to be, so womp womp. It's actually going to be H this time, so it wouldn't have probably done you too good. I have one question that's like 17 answers on it. So anywho, what other questions do you guys have on exam purposes? Obviously, it's going to be on Monday. Your prescription assignments will also be due. I think it's due on Friday or whenever Canvas says. And then you guys will be done with Pharm 1. So give yourselves a pat on the back. Congratulations for getting through the first third of your legit Pharm classes. We have 2/3 left to go next semester. But we also don't have EpiBio next semester, so that should thrill you to some degree. I know. So many people got told how horrible this class is from your upperclassmen before coming in here, and all of it was true, but you made it, right? So you rose to the occasion. Probably even worse in some cases, but you got through it. So I appreciate all of you being here with me. Again, from eval standpoint, like I really appreciate thoughtful evals, whether good, bad, or otherwise. So I really take to heart everything you guys say there. Any suggestions for improvement from a technical side, from a lecture delivery side, whatever the case may be. Who knows what next semester is going to look like. So I want to make sure I'm still giving you the best education you can, whether it's distant, in person, or anything in between there. But otherwise, I'm pretty much done with you guys for the day. Someone said, where do we get to find the most stellar equation for the writing exercise? I would go ahead and go to your PC or your Mac, whatever you use, open up a window and type in GOOGLE, and then you can just type in the most stellar equation, and I guarantee you will find it. Like I said, your Google foo is very important as a healthcare provider. If you can Google something, you can be halfway to being a provider right there. Yeah, it's not in the PowerPoint. Sorry, I'll give you a little bait and switch there. That's not sarcasm. That was being legit. Anywho, yeah. You're just going to type it in. The reason why I specify that though for real is that there are several BSA calculations that are out there, and so I just wanted to make sure that everyone was doing it consistently, so when everyone got the same numbers there. I didn't want any kind of any anxieties being made up over getting different numbers and stuff between people, so I specified there. Anywho, what other questions do you guys have? Anything at all? Otherwise, you're free to go. You can head out if you'd like to.
Doctor, would I have a question about the prescription writing assignment?
Yeah, what's up?
So I have a note on here, something about albuterol in Canada, but I don't remember what the question was. Somebody mentioned it.
Albuterol in Canada.
I have a note on my
Probably cheaper.
Okay, maybe it's not important. I already did the assignment and I didn't run into anything weird, but I wrote that down. So
for whatever reason, like every year I get like a rash of people that put in like salbutamol on their scripts, and I'm just like, we're in the US, we're not in the UK. What are you doing? Write that on.
Okay, that's probably what it was. I remember hearing it and writing it down, but I couldn't remember what exactly Canada had to do with that part of the assignment.
No, it's just the UK. So I don't know why people get that stuck in their head, the salbutamol, but that was it. Oh, I forgot to tell you guys my story, but if you want to stick around, you can. I'll just mention it briefly here. I had a call last night. It was like a 5 a.m. And basically, I had ER doc that was calling for a consult. They had a guy who got into a motor vehicle accident. And this will be recorded so I can listen to it later if they want. So the guy got into an MVC, and they had they do what they call a pan scan, which is kind of a short term for they just kind of scan everything with a CT scan. And they found these kind of look like little packets of something in the guy's stomach and small intestine. They're like, well, what the heck is this? And the guy did admit to using some crack cocaine recently. So the idea was that he was likely, I don't know what the full story was, but it was likely he was running away from the cops or something, or maybe got into the accident, was worried about the cops finding his drugs, and went ahead and swallowed them. So we call those body stuffers because they are trying to avoid, having police finding their medications there. So, or their drugs. So basically, he was calling and say, hey, what do we do with this? And you think, well, what's the problem with something like crack cocaine in the GI tract? Because the guy probably wasn't like nicely wrapping it and putting a Ziploc bag over it. No, he's probably just like shoving it in his mouth and swallowing it. So the concern is that cocaine gets interacts with the GI tract to cause significant vasoconstriction. So it constricts all the blood vessels. It prevents oxygen from getting to that tissue, and it starts to necrose, right? So then you end up getting like mesenteric ischemia, which can be quite fatal. So the concern was, okay, well, is this stuff going to be, is it going to unwrap itself and be released? That's a surgical issue. The surgery has to go in and actually get that out. So in order to prevent getting to that point, we had to do what we call whole bowel irrigation, where essentially you hook up the guy, usually with an NG tube, and use Go Lightly, which is usually used for like bowel preps and help out with constipation. But we can use Go Lightly to basically just flush everything out of the GI tract. And so that's ultimately what we ended up opting to do. We start out with a dose of charcoal. The charcoal will bind up anything that runs into drug-wise. So if that cocaine does unwrap, you give them that. And then you run the Go Lightly behind that and then just flush everything out. And then you just have them sit on a bedside commode, and they're probably miserable because they're sitting there just pooping their brains out essentially. But then you'd flush all that cocaine out, hopefully. And so again, we were monitoring for vital signs to make sure if he all of a sudden got super hypertensive or really tachycardic, then we would know, hey, something might be releasing here. We probably need to get surgery on board. So it's a pretty interesting case, not something you run into every day. But it's funny, comes in for the motor vehicle issue, and then now he's got a drug toxicology issue on top of that. So pretty interesting stuff, I think. So anyway, that's why I love ER. You always run into something you've never seen before. So all right, well, thank you all for being here. Appreciate it, and I will see y'all next time.